Hello, everyone. This is Haley Hansen. I lead the higher education team at Husch Blackwell. We're excited to give you today's presentations on who's in charge, student-athlete health through independent medical care, in partnership with the U.S. Council for Athletes' Health. Before we begin, I'd like to cover a few housekeeping items. At the bottom of your audience console, there are multiple applications to use in today's program. I'd like to take a minute and just highlight a couple of them for you. First, we encourage that if you have any questions, please submit them during the webinar. We will try to answer them during the webinar, and you submit your questions via the question box. If we do not have time to answer all the questions during today's webinar or a fuller answer is needed, we will email you and respond to your question individually. We do truly appreciate audience participation and encourage you to submit questions. If you have technical difficulty, please click on the help icon. It has a question mark, which provides information on common technical issues. A copy of today's slide deck, if you'd like to print it off or share it, is available in the resource list icon that looks like a folder at the bottom of your screen. This program has been approved for continuing legal education in Colorado, Illinois, Indiana, Iowa, Missouri, Nebraska, Tennessee, Texas, and Wisconsin, and credit for self-study credit in Ohio as well. To report your hours in Illinois, Indiana, Nebraska, Tennessee, or Texas, click on the CLE icon at the bottom of your screen and complete the questions. Also, a recording of the webinar will be available tomorrow for watching and sharing. This link will be emailed to you along with a certificate of attendance for attending today's webinar. Joining me today is Pete Land and Dr. James Borchers. Pete is a partner at Husch Blackwell in our higher education group and concentrates his practice on serving private and public sector higher education institutions and academic medical centers in a wide variety of counseling, investigation, litigation, and athletics matters. Dr. James Borchers is the co-founder of the U.S. Council for Athletes' Health. He is a leading expert on student-athlete healthcare. Dr. Borchers has over 20 years of high-level athletic healthcare experience. He also has a wealth of knowledge with consulting with other schools and looking at all aspects of student-athlete healthcare and safety. With that, we'll go ahead and start today's webinar. Our agenda for today is to cover athletic medicine, the expanding awareness in the public eye, talk about independent medical care and what that means, and Dr. Borchers will lead us through that, and implementing IMC, talk about the policy framework that schools should have, and the holistic approach regarding specific issues. So let's get going and talk about athletic medicine. And we put up a couple of definitions for athletic medicine from Webster's and Wikipedia, meaning that we are looking at the treatment of injuries and prevention of related sports injuries or related to sports and exercise. And as we look at that, we've seen in the last few years really a growing concern in the public eye, specifically looking at fairness issues, so roles of players and institutions surrounding whether student-athletes have a balance of power between themselves and their universities. There's been a number of cases that have examined this issue, and this expands far beyond the field of athletic medicine, but it has a lot of attention and media attention right now as well. The Me Too movement in a culture where we've seen increasing action by institutions as well as focused on student athletes surrounding sexual misconduct in athletics, we've seen a number of schools really be in the public eye when it comes to how they handle and respond to incidents of Title IX incidents at their institution. Also, new medical evidence in the area of science raises questions as to what are the appropriate approaches to athletic medicine and how should that or could that be regulated. And then finally, we've seen a number of player deaths, which has resulted in protests and resignations across the country as well. So this is definitely an area where we're seeing increased litigation. Specifically, we saw 300 lawsuits filed by former college football players playing out mostly in the Northern District of Illinois against the NCAA regarding concussion litigation. We've also seen litigation and the question of whether players have a right to play safe. Specifically, a couple in Texas filed a lawsuit saying that drills by their school district where they failed to enact or even enforce policies to limit helmet-to-helmet contact and conduct between the players showed to have caused head injuries, and that these led directly to litigation as well, and even malpractice litigation. In a case that was decided in North Carolina against a private institution, the question was whether or not the unlicensed medical or athletic trainer had enough background and expertise to determine whether or not a student athlete should be participating in their practice when there was extreme heat. So as you can see, there's all sorts of areas in which athletes' health is really right now in the forefront of the public eye. So with that, we're going to launch our first poll question, and we want you to answer this question. What do you see is the biggest driver of athletic medicine change? Is it internal best practice standards, public opinion, association rules, either through the NCAA or NAIA, other association guidance, legislation, or litigation that we just talked about? And as you can see from the results of the poll, it looks like public opinion is one of the main drivers that we just discussed. So let's talk a little bit about what we're seeing in terms of these changes with legislation. Specifically, we're seeing a lot of movement around various issues tied to athletic medicine. Currently, 49 states and the District of Columbia now regulate athletic training. Individuals must be legally recognized by the appropriate state regulatory agency before being able to practice an athletic training and pass an exam. We're also seeing that there is increased legislation, including the Sports Medicine Licensure Clarity Act, which was signed by President Trump last fall, which was a new law that improves legal protections for athletic trainers and other sports medicine professionals when they're traveling with their teams outside of their primary state of licensure to deliver that medical care. So there's a tremendous amount of effort looking at these laws and making sure that there are appropriate protections not only for our student athletes, but appropriate protections for our athletic trainers as well. We've also seen a couple of states, Washington State being the first way back in May of 2009, that has enacted its own legislation regarding training and safety for young student athletes and providing levels of controls for youth sports in that particular state to address concussions and other very serious medical conditions. Finally, we've seen some evolving standards, not only with the NCAA, and we're going to talk about those later in the presentation, but also that athletic conferences are really looking at how they're going to approach this issue as well. We've also seen insurance standards. We're seeing some signs that insurers are starting to exclude coverage for certain types of incidents where the institution isn't following best practices within the safety best practices for student athletes' health. So this is becoming increasingly something that you need to be aware of and make sure that if you do have these insurance policies, what is being excluded. And finally, we're seeing some shift in the law as well in terms of when a special relationship between a university and a student has been created and what type of liability that may lead for the university. There's a case right now that is going on with the University of of Toledo in Ohio, in which they're talking about issues where a school can be liable for issues in which they're team-sponsored events that are not sponsored by the coaches, but really by the student athletes. And so there's a lot of change as we look at these evolving standards. Clearly, one of the most fundamental ways we can protect these student athletes is to ensure appropriate medical care systems are in place. And at the heart of that system is independent medical care. And I'm going to turn it over to Dr. Borchers right now to walk us through independent medical care.
Haley, thank you so much. And to you and Pete, thank you for allowing us to join you today to talk about this very important topic that I know to many that are involved in secondary and especially collegiate athletics understand is an evolving topic that continues to get a lot of priority. Independent medical care in general is a concept we need to understand because as healthcare delivery, especially in collegiate athletics, has evolved, it's no longer just a necessity. And I think historically those that have been involved in collegiate athletics have oftentimes viewed healthcare as a necessity for athletes to be able to participate. But it is clearly a priority, and for many of the reasons Haley mentioned and others that we'll talk about today, it may be the most important priority for collegiate athletics. Quite simply, independent medical care provides the foundation to optimize the health and safety of athletes. And as you're going to see in the presentation, organizational structure will drive this function, and it's critical that organizations look at this as they're developing athlete healthcare models. Why do we need independent medical care? Well, at the foundation of independent medical care is the assurance that medical personnel have unchallengeable autonomous authority to make medical decisions for athletes. And as you heard Haley mention and others, athletic trainers are at the forefront of making these decisions. And they are oftentimes and should be partnered with physicians. And this partnership allows for excellent medical decision making, but it needs to be autonomous. Instituting independent medical care clearly decreases risk to athletes and maybe as importantly, decreases liability exposure to organizations. So athletic organizations and universities, institutions need to be having discussions and thinking about how independent medical care can be provided for both of those reasons. But independent medical care today in athletics, and especially in collegiate athletics, has an expanded scope. When I played college athletics, it was an athletic trainer and a physician that was involved in our care. But now we have defined medical team services that expands throughout many disciplines that need to be coordinated. We all know about the importance of mental health in collegiate and in athletics in general. There are nutrition specialists, physical therapists, massage therapists, and others that are providing care to student athletes. And then there's the evolving field of sports science and sport performance, which may be traditionally known as strength and conditioning, and the crossover between delivering medical care and the performance of our student athletes. And it's critical that we define those medical team services and how they're integrated. Accountability for all of these groups is important, and their roles and responsibilities have to be well defined in order for independent medical care to work well. And this is not something that has been traditionally looked at in collegiate athletics. Ultimately, medical reporting authority is to the team physician. And it's important that the team physician or the medical director be involved with not only athletic training, but with these other services to make certain that medical decisions are being made in a proper fashion and integrated appropriately for the student athlete. I think it's really important for us to take a moment to look at the guiding principles of independent medical care that were provided by the NCAA and Inter-Association Consensus Statement on Best Practices of Sports Medicine Management for Secondary Schools and Colleges. The first of these principles is that the physical and psychosocial welfare of the individual student athlete should always take the highest priority of the athletic trainer and team physician. And at its foundation, this is where independent medical care needs to exist. We need to make certain that our athletic trainers are empowered to make important medical decisions to care for our student athletes. The second principle is that any program that delivers health care to student athletes should have a medical director. It's important for everyone to look at their organization and make certain that that's well defined. The third principle is that the medical team should always integrate best current research evidence within the preferences and values of the student athlete. And again, this goes back to the principle of autonomy, making certain that the student athlete is counseled in this arrangement and relationship when making medical decisions. The fourth principle is that clinical responsibilities of the athletic trainer should always be performed consistent with protocols, verbal orders, standing orders, and an association with the team physician. There's no more important relationship in independent medical care than the relationship between the athletic trainer, who is at the front line, and the team physician. Athletic trainers provide most medical care to athletes and deserve the support of their physician colleagues in making that determination. They need to be empowered by universities, institutions, and organizations to make decisions without interference. The fifth principle is that decisions that affect long-term health of the student athlete should only be made by a properly credentialed health professional. Health professionals have to make healthcare decisions for student athletes, and those that are not credentialed to do so need to be excluded from that decision-making. The sixth principle is very important. The decision-making process should be well documented, and looking at documentation strategies, including electronic medical records and other solutions, should be one of the most important priorities when thinking about independent medical care. The seventh principle states that coaches must not be allowed to impose demands that are inconsistent with guidelines of sports medicine professional organizations. Everyone has to be held accountable to independent medical care, and coaches are at the front of that line. The eighth principle is that an athletic trainer's responsibilities and employment status should be through a formal role, including the medical director. Quite simply, medical personnel should report to medical personnel when it pertains to their medical decision-making responsibilities and professional employment. The ninth principle states that an athletic trainer's employment status should not be primarily judged by administrative personnel who lack healthcare expertise. That includes administrators and coaches that don't have background in healthcare. And the 10th principle states that institutions should adopt an administrative structure for healthcare delivery that minimizes potential for any conflict of interest that could adversely affect the health and well-being of the student athlete. There's not one approach that fits each institution, organization, or college best. Each institution has to look at their specific area and what their resources are in order to have the best system possible for independent medical care. When considering these 10 guiding principles, I think it will help guide us as we think about some of the other issues that come up with independent medical care as we move forward. Even though those principles are there, there are some real critical concepts for independent medical care that I think we have to consider. Maybe the first is recognizing conflict, because conflict exists in athletics. Athlete health and safety and an athlete's performance can be in conflict with each other. Why is that? Athletes in general are driven individuals. Sometimes they want to, quote unquote, win at all cost. And in fact, some of the greatest athletes would say they'd sacrifice their health and safety to be successful. Is this always the worst thing, that an athlete would push themselves to be more successful in their sport at sometimes hurting their own health? And who defines playing hurt versus being injured? Many athletes would say that they would play hurt, but who mitigates that risk and who makes those decisions? And oftentimes we find ourselves having a difficult time rationalizing this conflict, because we know that athletes want to perform, but we also know that they need to be protected and be kept healthy and safe while doing so. This conflict, when we think about it, is often unintended. The conflict is everywhere in society. We all want to win. Athletes want to win. Coaches want to win. The parents of athletes want to win. The fans of a team want to win. And administrators want to win. Everyone wants to win, and that's not a bad thing. But that can also affect healthcare personnel, because they can be biased by this desire to win. And this bias can then permeate their decision-making. It's the culture of athletics, and anyone that's involved in athletics knows that this exists. But we have to minimize this phenomenon for our healthcare personnel. If we go back to the first principle provided by the guidelines, it's the physical and psychosocial welfare that needs to be at the forefront. And we have to allow our medical personnel to make those decisions. And independent medical care and its basis can help us do that. If we identify that there are other critical components of independent medical care, it might seem that implementation would be easy. We just tell our medical professionals they make medical decisions and no one else does. But the actual implementation can be very challenging because medical care in general and independent medical care does not evolve easily from historic patterns of athletic administration. Athletic organizations at every level are not healthcare organizations. They are not put in place to deliver healthcare services. Yet more and more we're finding that they need to evolve to have patterns of delivering healthcare to athletes. We often find that there's antiquated organizational structure that does not allow for modern function for independent medical care. Oftentimes when we're asked to consult and work with organizations to help them institute independent medical care, the starting point is with organizational structure. It's that organizational structure that is critical to independent medical care function and delivering adequate health care and providing safety for student athletes. When we talk about the implementation of independent medical care, there's lots of resources that we need to consider, but some that are critical. One, when you think about your organization, is healthcare resources. And again, one of the reasons implementation of independent medical care can't be uniform for all organizations is that each organization, university, college is unique, and the resources they have that are unique. There are some resources available to some institutions that have academic medical centers and tertiary care centers. We have to look at what that resource availability is. Who are the personnel that are available, and how are they associated with your organization? What facilities do you have to deliver health care? What equipment is available? Are you associated with a medical school? Do you have a relationship with a hospital or a health system? Is there an affiliation? Or are those possible? And it may be that in traditional patterns of delivering health care to athletes, those organizations weren't looked at. But it's more critical now than ever to make certain that if those affiliations exist or are possible, that those relationships are explored, to make certain that healthcare resources are provided to student athletes in the best possible fashion. So this leads us to our next poll question. One of the questions that we mentioned before was about reporting strategies. So to whom do your athletic trainers or team physicians report most directly at your organization or institution or college? Is it to a coach? Is it to an administrator? Is there a physician? Does it depend on who the trainer or the physician is? Or are you just not sure who they report to? And this gets back to our comment about organizational structure and who these medical personnel report to in order to deliver independent medical care. And so if we take a look here, you can see that most respondents state that their medical personnel report to an administrator. And I think as you'll see here in a little bit, the question is that administrator appropriate for having a reporting line for making decisions about medical care? And if not, how can that be looked at differently in your organization? It's interesting that only 28.6% of respondents mentioned a physician, and that over 10% were not sure, and about 9% reported to a coach.
You know, Jim, if I could just interject for a minute, I was interested in this poll result before it came up because in our experience in doing various reviews and investigations or interview a lot of medical personnel, particularly athletic trainers, you find that their perceptions of this question vary greatly, I think, depending on their particular circumstance, maybe the particular coach they're working with or the degree of organizational structure they feel surrounded by. But it's also, I think, reflective of how athletic trainers have to balance so many interests, both in getting information, good information from the student athletes about their health and wanting personal connections with them and with the coaches, but also wanting clarity about their professional responsibilities and their ability to make the judgments that they really do need to make. So I think the sort of variety of those answers there reflects how I think athletic training staff feel as well in particular.
And Pete, just to kind of add on to that, I'm sorry. I was just going to add on to that, Pete, to just say that, as we were talking about in the public eye, that a lot of these things that are in the public eye in terms of improvements and legislation are being pushed by athletic trainers as well. They are looking at all of these different things to balance to say, how do they make the best decisions that they can. So I totally agree.
Yeah, and I think those are great points, and I think we have to remember, oftentimes it's interesting that individuals view the role of the athletic trainer differently, but an athletic trainer is a healthcare provider, and they're there to provide healthcare in a very unique environment to athletes, and it's a challenging environment to provide healthcare, and they need to be supported appropriately, and your points are well taken that when there's confusion in how that role needs to be served, it can be very difficult to make those decisions. Well, let's continue to talk about implementing independent medical care and some of the things that we need. We mentioned organizational structure, and it may seem like we've talked about this quite a bit, but organizational structure, as you can see from even reporting lines, can really help cement the concept of independent medical care at your organization or institution. It's really critical, as the principals mentioned, to identify a medical director, or even more appropriately, depending on the size of your organization, a chief medical officer. Oftentimes, that role should be served by a physician if possible. And that's because most athletic trainers need to have that excellent relationship with a physician and need to have the support to make the decisions that they need to be made in conjunction with the physician. So that relationship needs to be cemented in organizational structure. But medical personnel need to report to medical personnel, and most critically, as was just mentioned, when they're making health and safety decisions for athletes. I think it's been made very clear that coaches are not medical personnel, and that the reporting of medical personnel to coaches institutes an extreme conflict of interest when we're talking about how to deliver health care to an athlete. And coaches are not necessarily defined just as sport coaches, but that could be, for example, a sports performance coach or other coaches that are not defined traditionally as coaches in athletic organizations. It's important to remember that administrators might be medical personnel, and there are excellent administrators out there, many of them with backgrounds in athletic training, who have been able to institute independent medical care models at their colleges or universities and have really been leaders in this area in working with physicians and other clinicians to provide independent medical care. Unfortunately, in many situations, administrators without healthcare background are put in leadership roles over medical decision-making, and this does not lead to the best solution for independent medical care. That being said, the collaboration with athletics administration is crucial to success. Leadership in athletics administration needs to support independent medical care for this culture to take place, and it doesn't happen overnight, as we know. This culture can take time to develop. Administrative support is crucial, as I mentioned, to independent medical care success. It's critical that administration works to avoid conflicts and confusion regarding independent medical care and how it's delivered. Many institutions have worked towards policies to help define independent medical care and have given examples to coaches and other staff on how they could be unintentionally interfering with independent medical care. Independent medical care is a culture. It's not just a piece of paper. It's not just an organizational chart. It has to be developed at your organization or institution. Maybe most importantly is communication and transparency. In healthcare, privacy is important, but the idea of independent medical care needs to be communicated and needs to be transparent. At your institution, student athletes must understand the concept of independent medical care. They need to be educated on the fact that medical providers will be making medical decisions for them and that they'll be working with them to make certain that their health and safety is paramount when making those decisions. But everyone must be aware of the concept of independent medical care. Anyone in the organization. No one gets to disown their accountability when it comes to health and safety of student athletes. Policies, as we're going to hear about in a minute, need to be clear and transparent. And questions regarding independent medical care must be addressed timely. We can't let these situations fester and go on for long periods of time before addressing them. Addressing these questions in a timely fashion will clarify things for individuals in your organization and also make certain that independent medical care and medical personnel can perform their duties appropriately. Pete?
Thanks, Jim. Hello, everybody. Good afternoon. Again, my name is Pete Land. I'm going to talk a little bit about policy framework within athletic medicine. And I think of it this way. As a former college athlete myself, my father was a coach at a Big Ten university. I grew up around university athletics, and university athletic departments are largely built on relationships and ideas of toughness and passion for competition, and not always about adherence to technical rules, particularly in the area of athletic medicine. But it's important that the policy framework that's set up in your institution gets institutional buy-in to the rules and the ideas that are intended to be set forth to help advance the ideas of independent medical care, and that they're not just viewed as issues that the physicians and athletic trainers are supposed to figure out and administer as a medical matter. I think there's more of a policy idea or a cultural adjustment that can be obtained through policy framework. With that in mind, let's start with a presentation about policies with a poll question about who owns the athletic medicine policies and procedures at your institution. In other words, who's responsible for helping frame them out, for helping define what they say, what they don't say, and how they're distributed to others on campus and the constituencies that are involved. Are they owned by the athletics department itself? Are they owned by a separate athletic medicine department? Are they owned by the outside physicians? Or are they owned by the lawyers, the general counsel's office? Let's see what people think. So I think this is interesting. We're mostly seeing that the folks are thinking that it's the athletics department itself that owns those policies, with large contributions probably from outside physicians as well as a separate athletic medicine department, and then maybe a little bit of oversight from the general counsel's office. Part of the reason to start with this idea is, from our experience, what we find is that it's just important that these policies are considered to be owned by everyone involved in the athletic department function, and not just the doctors and the athletic trainers, and that it needs to be a coordinated effort in defining what the policies say and how they're distributed and how transparent they are, instead of kind of a hodgepodge set of technical standards that have been put together over a series of years without really any kind of comprehensive approach, which is not uncommon to see. And it's important to avoid, because otherwise what you end up with is just kind of word of mouth that gets passed down from different people about how different procedures and different processes should work within the athletic medicine function. And that's what you're trying to seek to avoid in a modern structure. So in talking about policies and procedures that apply in this area, you can see, I'm not going to go over every specific policy that could be addressed and every specific medical technique or approach, and there are many, but I think it's important to identify some of the key areas. And one of the most important areas is to make sure that policies and procedures that exist support reporting protocols, meaning that student athletes know that if they report that they have an issue, a health-related issue or an injury-related issue, that something's going to be done about it, that they're encouraged to report it, and just as importantly, that if the folks who administer athletic medicine, athletic trainers, doctors, to some extent, any strength and conditioning coaches that are helping with training, that if they feel like there's something that's going on that's not right in how the procedures are being implemented, that they know who they can report to and that something is done about that. That's incredibly important for your policies and procedures to communicate to people. It's also important to have management plans for concussion management or heat-related illness or other areas like that, to have everyone understand how those situations will be dealt with. There's one example recently, a case from a year ago or so, involving American University, with, just using as an example, with a Division I field hockey player with a concussion who reported signs and symptoms associated with a concussion internally, including emails to their team training staff, and was not, in her view, not properly diagnosed, not properly safeguarded from her return to play, and continued to participate and eventually developed more problems, more damage. In that case, the court allowed her case to continue past a motion to dismiss and identified what it viewed as a special duty that the university, its agents and servants and employees, so the people administering the athletic medicine standards, they under a special duty to act reasonably and take precautions to minimize the risk of injury. And it's important that our policies and procedures are set up so that people understand they need to follow through on such things. It's also important on a broad level for our policies and procedures to feed into other policy systems. So whether that be Title IX with respect to sexual misconduct issues or other employee discipline or student discipline issues that might involve interpersonal behavior, it's important for our policy statements to refer to those so that people know where to go with those kinds of concerns as well. Now, looking more specifically at the independent medical care concepts that Dr. Borchers has been talking about, I think some ideas to keep in mind that our policies and procedures need to address is that the degree of different constituencies that are involved in administering and helping make sure that independent medical care is actually a reality instead of just a concept. And all of these different participants have to be able to understand how they're supposed to implement the rules and their roles within the athletic department. And so I say all of that because if you look at the various standards that exist that define independent medical care, either from the NCAA, like what Dr. Borchers was reviewing, or maybe from your particular athletic conference or your particular institution, they all clarify a pretty straightforward rule. The doctors and the athletic trainers are in charge of medical decisions. But it's important that people understand how that's supposed to play out with more nuanced questions in your policies that are addressed. So for instance, which group of people should be addressing student-athlete training and wellness, and which one should address which issues? Where is the line between treatment management and someone returning from from an injury with an athletic trainer and actually starting to train again to develop their athletic prowess with perhaps a strength and conditioning coach? Where is that line? And who decides when they've crossed that line in the particular context of particular types of injuries? It's important to make sure to coordinate information flow and return to play plans between those different constituencies and to have policies indicating that those are good ideas. The reason to clarify that kind of information in policies is that it gives the people who have to implement these issues a starting point to raise a question when they think that something's not right. In other words, instead of them just saying, I think that this should be done differently, there's a policy they can point to say, here's how we're supposed to work together. I don't think this is happening. Can't we change how we're proceeding? It's important for that to be clarified in policies. And that kind of clarity also allows managers or administrators who are not themselves athletic trainers or physicians the ability to respond and to deal with issues as they come up. And it's also important for that to be clearly communicated with student athletes themselves through policies and procedures. I'll list here some other issues that are important to identify in your policies, I think, because these have come up more and more. Weight management or eating disorders, how will those be addressed? And dealing with outside referrals, who can refer to outside physicians? When should that happen? What kind of communication internally should occur? before that happens, and what do student athletes and their families know about that issue? It's important for that to be something that people understand. The last one has to do with new treatment methods and devices. There are ongoing innovations within athletic medicine and training, particularly in the training function and improving strength and conditioning, and how are those new approaches going to be vetted? Is it a multidisciplinary group that will review those issues in some way or not? And if so, it's helpful to clarify that in your policies and procedures so that people don't just either ignore a good idea that's new or implement it on their own without oversight. I'll talk briefly about disability considerations with respect to discrimination and then move on to some mental health issues that I think are particularly important. In the discrimination area, there are examples still of student athletes that have health-related issues that they believe they can push through. So an example of a case involving Southern Mississippi, the University of Southern Mississippi this last year, with a football player with one kidney who wanted to keep playing and was not allowed by that institution. He sued claiming that he was being regarded as having a disability, and that suit was allowed to proceed past a motion to dismiss, meaning they're going to have to defend it. And I identify that not to say that there are easy answers there, but if an issue like that arises, it's important to make sure that people have some policies about who's going to help figure that out and how to make those kinds of decisions. With respect to mental health issues and scholarships and privacy, the basic point with scholarships is that under NCAA rules, you're not allowed to take away scholarships based on performance alone, and that should apply as well to any kind of issues with performance that someone may think come from mental health issues or medication related to mental health issues that has an impact on performance, not to allow that to impact decisions on scholarships. And we'll talk more about privacy and confidentiality because I think that's a fundamental area in mental health issues that student athletes need to understand through policies. This slide is intended to identify a good source of information if you're looking to implement policies in the mental health area, which is the NCAA best practices. They're listed here, and you can find them on the NCAA's website. Mostly they set forth some basic ideas that you should have clinical licensure for any providers of mental health, that procedures to identify and refer student athletes should be clear to people. There should be some kind of pre-participation screening for what we think of as chronic mental health issues. And then there should be some support, a lot of support for mental well-being and resilience and create an accepting culture. And I want to talk a little bit more about that as we move through with respect to policies and procedures, because I think this is an area where student athletes and coaches don't always see things exactly the same way. And here's an example of why that might be. The basic idea in mental health issues is that once they exist, coaches should keep their hands off of them and not involve themselves in trying to figure them out, or even in getting information about the existence of mental health issues. But people are sometimes afraid to report them because of a stigma within athletic culture. Student athletes are supposed to be tough. They're supposed to persevere through challenges. And sometimes there's a perception that mental health issues might be the opposite of that, even though they're not. There may be a concern that mental health-related medications could affect performance and that that's something to avoid. Another challenge has to do with personnel who are not mental health providers providing advice or counsel to student athletes from their own personal experience or family experience. It may be well-intended, but it's not a good idea, and your policies and procedures should address that. And there is also resistance sometimes from coaches who manage programs from going from knowing everything about their team members to not knowing anything about something that's really critical to one of their student athletes that they care about and have come to know and who they want to help take care of, but they should keep their hands off that information. This slide is a little busy, but it's intended to help provide a list of ideas to keep in mind for addressing these challenges. I think particularly important is for coaches to know that the information about student athletes' mental health is off limits to them unless the student athletes want it shared. I'm constantly amazed in talking to different coaches and the work that we do that basic concept is something that they have a difficult time adhering to with respect to particular players or with respect to particular circumstances because they want to help. They want to know what the student athlete is experiencing. They may have well-intentioned efforts to try to help them manage things, but that can be harmful to the student-athlete, even being willing to report the concern and have it addressed. And it's important to reiterate that consistently through your policies and procedures to coaches, and to make it clear to them that any negative commentary or jokes about seeking help are something that should never happen. Student-athletes should also know from the policies and procedures exactly what's going to happen with information that they share about their mental health concerns. That can be a reason for many of them not to share at all, and they should understand that their coaches will be left out of that flow of information if they want that to be the case. Hopefully the coaches will reiterate that themselves so that the student-athletes feel comfortable getting the help when they need it. And it's important to have a strong mental health professional presence to the extent an institution can support that, so that people know those people and respect them and understand that they have authority to help and not to share information in ways that it shouldn't be shared. Aside from mental health issues, here's a few ideas to have with respect to policies and procedures and other issues for protection. One has to do with waivers and obtaining waivers from student-athletes. Assumption of risk is still a part of athletics. We all know that participating in athletics can result in injury, and waiver language can be enforceable if it applies applicable state law standards, so it's important to make sure your waivers are up to speed with your particular state law. And it can be helpful for them to be plainly written so that they can serve as a tool of educating student-athletes as well. Another idea to keep in mind is to have your systems reviewed, which means that we need to go through our policies and procedures with groups of people to understand with some regularity instead of just having them sit there on a shelf, so we understand that we're following best practices and that a group of people is trying to implement them. And the last issue is enforcement of our standards, and policies and procedures are only worth what is enforced. It's important to publicize them so that people know about them, particularly think about online policies that parents and student-athletes can review on their own. And when we learn of any concern with adherence to these kinds of policies, that there's follow-through and zero tolerance for violation of any independent medical care standards. And that kind of goes into some of what Dr. Borchers was talking about before. We like to think of it as you want your institution to move beyond compliance, more than just what's required, but take the culture of excellence that your athletic personnel apply to their competitive endeavors and apply that to the independent medical care endeavors and to the protection of student-athletes and to the flow of information that's needed to make good medical judgments. And to do that, you need the organizational structure that Dr. Borchers was talking about that provides the authority behind the athletic trainers and the physicians, but most importantly that your athletic director and the leaders of your athletic department are actively supporting the athletic medicine function, both in their words and in their actions, and that's something that happens on a repeated basis so that people know that the culture within that particular athletic department values the folks who provide independent medical care. And with that, I'll turn it back over to Dr. Borchers.
Pete, thanks a lot. As you were talking about that, it led me to think about, in medical programming in general, whether we think about medical education or when we think about healthcare delivery in many different settings, whether a hospital setting or an ambulatory setting, it's really standard of care to have independent external review to make certain that those standards and that accountability is met. And athletic medicine has been one of the last areas of medicine to really adopt this sort of standard. And so one of the ways that organizations can help show that culture of accountability is to engage in independent external review. And I think we're going to see more policy from organizations calling for that and that engagement of transparency, as you mentioned. And so that's an area where I think there's going to be continued growth. So your comments are definitely right on target as it pertains to independent external review. Let's talk just for a little bit about the holistic approach and some specific issues for independent medical care. And I think just to put some concepts in place and then share some examples about how this can be applicable outside of just caring for a student athlete in what we think of as the traditional setting, maybe in an athletic training room or in a physician's office. Let's start by defining what independent medical care does not mean. What it does not mean is that the medical team exists in a silo by themselves, that they're walled off and separate from the rest of the athletic group. The medical team really needs to exist in conjunction with, and as you've heard here today, in a matrix that interacts with many other disciplines to make certain that medical care is being delivered appropriately. And that can be a little different from traditional structure of how athletic medicine's been delivered. Independent medical care does not mean that the medical team has sole responsibility for health, safety, and well-being of student athletes. I think you've heard today that that culture needs to be pervasive throughout the organization. But everyone needs to recognize the importance of independent medical care so that health and safety and well-being of student athletes is met. Medical oversight is needed for many areas of collegiate athletics. It doesn't just pertain to the individual student athlete. It pertains to safe environments, and you've heard today about some of those environments. That may be facilities. It may have to do with temperature, cold or heat, or those sorts of things. It's safe training practices, safe practice and competition environments. And so medical oversight is needed there to make certain that health and safety is met. And beyond just injury, illness, and some of the things that we think of traditionally for athletes, athlete well-being needs medical oversight, making certain that athletes' well-being in their day-to-day is being met. And that's also encapsulated by independent medical care and something that organizations need to think about. One of the things I want to finish with today is just to think about one example of where independent medical care can cross over or coincide with different areas. And as I mentioned to you earlier, sport performance and sports science continues to be an emerging field. And I think there's been a lot of discussion in many areas about the role of sports science and sport performance and the crossover in medical care. But think about the areas of sport performance where education and compliance of important medical topics are needed. We unfortunately continue to hear about cases of exertional rhabdomyolysis, which is a condition where extreme muscle damage occurs secondary to extreme training conditions. And although not often intended, it's often lack of education and then compliance around this topic that leads to these issues. You've heard us mention here, talk about heat illness, and certainly the issues around sport performance, and then body composition measurements. And you heard Pete mention earlier the ideas behind weight management and body composition. Who owns that data? Who communicates that data? And who's responsible for it? And what about emergency action planning? Are sports performance professionals involved in that emergency action planning? Do they understand it to make certain that if something happens, that they're prepared to handle that emergency if medical personnel is not immediately available? Are they CPR or basic life support certified? Do they know how to operate an AED? And do they understand the emergency action plans of the university? All of that requires medical oversight. What about training methods and assessing safety and certification? What about hands-on treatments that may be performed by non-medical personnel, like reflexive performance reset, which is a technique that's used by many sports performance professionals to improve training, where they're laying hands on athletes? What about oxygen deprivation training and the safety of it and how it's provided? What about modalities and equipment, things like electrotherapeutics or other new modalities, and who oversees that? And what about training and performance versus treating injury? And you've heard that earlier in the talk, the idea between when is an athlete returning from injury and returning to training? And is there cooperation between medical staff and sport performance to make certain that that's happening appropriately? And do you have oversight of how that occurs? What about all the new technology and information that's available in sports science and sport performance today? There's probably no area in athletics that's growing more than technology and information around sport performance. There are systems now, Catapult and Zephyr being a couple, that can measure all sorts of variables from heart rate variability to other things. There's Omega Wave and biofeedback mechanisms. What do we do with that information? What about wearable sensors that may be measuring sensitive health information and potentially protected health information for individuals? Who's counseling those athletes on that information, and what are we using that information for? And then recovery. Certainly performance and sport science focuses not only on the training of an athlete, but on recovery. And how about sleep monitoring and the best way to do that? What about other modalities such as float technology and float tanks, laser treatments, and dry needling? And what about nutrition planning? And when we think about disordered eating and body composition, who's involved in those processes? All of this could be traditionally looked at as sport performance or strength and conditioning, but certainly needs medical oversight to make certain that health and safety of athletes is protected. Just want to review, after the talks that you've heard here today, some of the key takeaways, as I'm sure you have a lot to think about when you think about your organization, institution, or college as you return thinking about independent medical care. It's really important to make certain that you realize that independent medical care is the foundation for optimal athletic health care and health care delivery. There are critical elements to consider when you think about independent medical care, as you've heard illustrated today. Organizational structure is where you need to start, and as you've heard, policy, procedure, and monitored and enforced systems are paramount to making certain that independent medical care isn't something that we're just giving lip service to. It's not something that's just on a piece of paper that's in a manual somewhere. It's part of the culture of how student athletes are taken care of. And independent medical care should extend to guide oversight of all aspects of health and safety for athletes to make certain that student athletes are getting all they need to ensure that they can participate healthy and in a safe environment. Pete?
Yeah, thanks, Jim. And I see we have a few minutes left here, and we've received quite a few questions, so we'll see if we can go over some of them.
Sounds good.
And Jim, I'm interested in your thoughts about one particular question I see here, which is a question about who should evaluate team physicians and their performance, the team physician's performance. The options given by the questioner have to do with, should it be another doctor? Should it be the director of athletic training? Should it be an administrator? Should it be a combination of those? What are your thoughts on who should be evaluating the team physician's performance?
Yes, the team physician's performance should be evaluated by those that are qualified to do so, which is a chief medical officer or another physician with expertise in that area. And it's really not appropriate for an administrator, an athletic trainer, to, especially from a medical standpoint, to be evaluating a team physician. Now that can be challenging in some environments, but setting up a system where the team physician is evaluated by other medical personnel, and for example, if there's an affiliation with a healthcare system, having a relationship with that healthcare system that helps with that evaluation with input from the athletics department can be a model that can be used. But that's why we think it's so important to identify a medical director or even a chief medical officer to be involved in those evaluations.
Thanks. And I see a comment from someone else that's related to this that has to do with indicating that in their situation, they're the director of sports medicine and report directly both to the head team physician, but also that director of sports medicine also reports to one of the senior associate athletic directors. And the comment talks about how they view that as such a positive development because it means that the director of sports medicine also sits in on the athletic director's weekly meetings with their assistant athletic directors and gives the sports medicine department a voice at that table. And I think that's another example of the organizational structure that helps kind of integrate the medical function within the organization. Another question we see here is a question about how, another reporting organizational question, Jim, about strength and conditioning staff and your views on whether or not they should report to sports medicine staff or to someone else, or maybe to someone who oversees both of those functions. What are your thoughts on that?
Yeah, I think if you're asking my opinion, I think as I mentioned there's so much that crosses over that I think that the medical director of any athletic healthcare system needs to have oversight and ability to mold the sport performance area. So I think that that they should report up through medical for those issues. And so I think that strength and conditioning should have a reporting line that goes up through athlete health and safety. And I think if that exists, there's a lot of positives for everyone in that area. Again, it helps improve coordination, and it also helps make certain there's not questions or blurred lines between how injuries or return to play is dealt with.
So, thank you. Let me close with one other question for you, which is, and before we let everyone go here today, and I see on time, what do you think are the biggest impediments to institutions following the independent medical care standards that you've been talking about today?
Well, I think one is that it's not a traditional, high priority for athletic departments. And obviously, athletic departments, their priorities are around student athletes and their ability to participate, but around teams and success and winning and providing them the ability to perform. And unless independent medical care is brought to the forefront as a priority, it's going to sit somewhere in the background and other things become more important. Most athletic departments are large organizations, and so without that priority given to it, it can be problematic. And then I think the other thing is, Pete, is just organizational structure and the lack of structure to allow that function to be delivered in an independent fashion. And so oftentimes there's so much conflict from reporting or how the organizational structure looks that's hard to institute independent medical care.
Okay, and thanks for that, and thanks for all the other questions that were raised. In the interest of time, we're going to have to move on, but we will endeavor to respond to those questions offline in the coming days or in next week. So thank you very much, and thank you everyone for joining our program today. We hope that the information was helpful. If you haven't already done so, if you could indulge us by clicking on the survey icon that's at the bottom of your screen and complete the short survey. We love feedback from our webinars. It helps us plan quality programs in the future. And again, as a reminder, this program has been approved for Colorado, Illinois, Indiana, Iowa, Missouri, Nebraska, Tennessee, Texas, and Wisconsin's continuing legal education credit, and in Ohio for self-study credit. Also, a recording of the webcast will be available tomorrow for watching and sharing. And once available, a link to the recording will be emailed to you along with a certificate of attendance. That recording will be available for 2 weeks. So please be sure also to join us for our next webinar. It's going to be about service and emotional support animals managing the menagerie, and that's on March 25th. So thank you. This concludes our webinar, and we appreciate your time.